Good afternoon. My topic for today is hepatocellular carcinoma. So I'm Dr. Akshaya, Assistant Professor in the Department of General Surgery. So first we'll see about the incidence. So hepatocellular carcinoma is the most common primary malignancy of the liver. It is also the most common malignant neoplasm worldwide. So the incidence is mostly high in Southeast Asia and Africa. Males are predominantly more prone to get the disease. That is about 8 to 10 times they are more prone to get the disease compared to the females. So the incidence, as with early malignancies, it increases with the age. So moving on to the causative factors, the most common causative factor is the viral infections. That is mainly HPV, hepatitis B virus. So about 75 to 85% of HCC are related to HPV. And also about 76% of patients with HCC have found to have antibodies for HCV. So other factors include environmental factors, which is aflatoxins, and smoking, alcohol, cirrhosis, and oral contraceptives. Moving on to the clinical presentations. So it is most commonly seen in men around the age group of 50 to 60 years of age. So the commonest presentation would be right upper quadrant pain. There could be a mass palpable for abdomen. With any malignancy, there could be a loss of weight, and the patient can also present with a hepatic decompensation, and other non-specific symptoms can also be present. So one of the rarest of the presentation would be the patient presenting with shock, that is because of the hepatocellular carcinoma rupture leading on to the intraperitoneal bleeding. Moving on to the pathological types. So there are three different types, which is hanging type, pushing type, and infiltrative type. So in the hanging type, the name it suggests, so there will be a lesion that will be connected to the liver by a small stalk, that is a vascular stalk. So that can be resected without affecting the non-carcinogenic liver because it has a stalk. So the non-carcinogenic part of the liver can be very well preserved. So with the pushing type, it is an encapsulated lesion that can be seen pushing the vessels without actually invading them. So this, as it's not invading the vessels, this is also very well resectable. But with the infiltrative type, with the name, it infiltrates, that is the tumor invades the neighboring tissues, that is making it non-resectable. So this is the picture showing the tumor invading the portal vein and also expanding tumor. So this is a type of an infiltrative hepatocellular carcinoma. Moving on to the diagnosis, mainly it is the imaging modality, that is ultrasound is the first investigation of choice for screening and early detection. And the main definitive diagnosis that could be, and for the staging, we are going to take a CT, contrast enhanced CT, and an MRI. So you can also detect the extent of the disease, that is local, vascular, and biliary involvement, and the metastasis. AFP. So this is only an adjunctive test, it's not diagnostic. So the monitoring, this is helpful in monitoring the treated patient for the recurrence after normalization of the liver. That is more than 20 nanogram per ml will be usually seen in the patient, about 75% of HCC. False positive can also be seen in chronic viral hepatitis. And the specificity and positive predictive value improves with a higher cutoff value. That is, if the AFP is more than 400, it is the positive predictive value is higher. So we have a European Association study of liver diseases where we'll go about the diagnosis, like how to evaluate. And first you see a mass or a nodule on an ultrasound. So what do? You check for the size of the nodule. So if it's going to be less than 1 centimeter, what you have to do is repeat an ultrasound at 4th month. Okay. Then if it's going to be, you have to look for it whether it is growing or changing in character, or if it's stable. So if it's going to be stable, you have to repeat the same. That is, again, repeat the USG on the 4th month. But if it's growing or changing in character, you have to look for the size again. If it's going to be 1 to 2 centimeter or more than 2 centimeter, and proceed with it accordingly. So 1 to 2 centimeter. If you find a nodule of size 1 to 2 centimeter, you proceed with a 4-phase CT or a dynamic contrast enhanced MRI. Then you have to look for any positive techniques in HCC, radiological hallmarks, if any present. So if it's going to be present, so you have to diagnose it as HCC. If it's not, you have to proceed with the biopsy. Then if it's going to be more than 2 centimeter, you're going to repeat the same CT or a dynamic contrast enhanced MRI. With the positive findings, you're going to conclude this at HCC, and with the negative finding, you're going to proceed with the biopsy. If you find both the biopsies to be inconclusive, you have to again repeat the ultrasound at 4 months. So what are the radiological hallmarks we were talking about earlier? Is the arterial enhancing mass and the washout of contrast in a delayed phase. So this is the arterial phase in the first picture on the left side. So where you can see a mass which is getting washed out in the later stage, that is the portal venous phase. This is the hallmark of a HCC, radiological hallmark. So how do you diagnose? So the patient with appropriate risk factors, like we said, HBV or HAV, and with the radiological hallmark, that is washing out in the portal venous phase, with or without AFP. So that's why AFP is only an adjunct, it's not for diagnosis. So with or without AFP, they do not require preoperative biopsy unless diagnosis is in question. So you can very well proceed to treat them as HCC if they have an appropriate risk factors and the radiological hallmarks. So FNAC, what is the role of FNAC in HCC? It is very limited because of the risk of tumor spillage, rupture and bleeding. So what are the common metastases in HCC? Is the lung, bone and peritoneum. Because lung metastasis is more common and they are asymptomatic, so CT thorax is mandatory in case of an HCC. Preoperatively, CT thorax should have been done for the patient because they are mostly asymptomatic. But unlike in bones, there would be symptoms present like backache. So bone scan is not routinely employed. They are taken only if there are going to be any symptoms. So we can also do an ICG clearance test for considering treatment options. So there are various different stagings. The most commonest we use is child-Turcotte classification. The others include MEL scoring, clip staging, ocular staging and TNM staging. So talk about child-Puke scoring. So we have various factors to take into consideration like total bilirubin, serum albumin, PTINR, ascites and hepatic encephalopathy. So if the total bilirubin is less than 34, you're going to give 1 point to it. If it's between 34 and 50, you'll give 2 points to it. And it's more than 50, you'll give 3 points. And if the serum albumin is more than 35, you'll give 1 point to it. Between 28 and 35, you give 2 points. And between 28, you'll be giving 3 points to it. And with the PTINR, it's going to be 1 point for less than 1.7. 1.7 to 2.3, you'll give 2 points. More than 2.3, you'll give 3 points to it. With ascites, it's going to be none, mild, moderate to severe. You give 1, 2 and 3 points accordingly. With hepatic encephalopathy, if there is no hepatic encephalopathy, you'll be given 1 point. And if it's mild, that is grade 1 to 2, will be awarded 2 points, and 3 to 4, it's 3 points. So we have to calculate the total points, and with the total points, it is again classified into class A, B and C. So the points is ranging between 5 and 6, we are going to put them in class A, and between 7 and 9, you have to grade them in class B, and between 10 to 15, it is class C. So the 1 year survival rate for class A is about 100%, and in case of class B, it is 80 and 45 with respect to class C. So ocular staging, the factors we take in consideration are ascites, albumin, bilirubin and the presence of tumor involving more than 50% of liver. And we have clip staging as well, that the clinical parameters include child-Puke class and tumor morphology, AFP and portal vein thrombosis. This score ranges from 0 to 6. About 4 to 6 is considered a very advanced disease, and 0 to 3 as a potential long-term for survival. So BCLC staging and treatment schedule. The Barcelona Clinic liver cancer staging. So it is classified into stage 0, A to C and D according to child-Puke and other stagings. So 0 is basically child-Puke A. It is a very early stage. That is there is only a single tumor less than 2 centimeter. That is considered carcinoma in situ. So we have to say if it is single and there is no portal venous pressure and the pressure is normal, you have to go for a resection. But if it's a single tumor with an increased portal venous pressure, the other factor you have to take into consideration is they have associated disease or not. If they have associated disease, you have to go for a percutaneous ethanolamine injection or radiofrequency ablation, and if they doesn't have an associated disease, you go for a liver transplantation. So the same goes with the early stage. Early stage includes single nodule or 3 nodules less than 3 centimeter. It's going to be less than 3 centimeter. You take into consideration of the associated disease. If yes, go for a percutaneous ethanolamine injection. If no, liver transplantation. With stage A to C, we have multinodular tumors and advanced disease. In the intermediate stage, when it is multinodular, without the invasion of the vessels, that is portal vein is not involved, you go for a chemoembolization. If at all the portal vein is involved and there is N1, M1, which is considered as an advanced stage, in those cases, we have to go for another new agents. In stage 3, which is the most terminal stage, style puke C, you go only give a symptomatic management. So what are the treatment options available? We have surgical, that is a resection, orthotopic liver transplantation, and we have ablative procedures like ethanolamine injection, acetic acid injection, thermal ablation like cryotherapy, radiofrequency ablation, and microwave, and transarterial like embolization, chemoembolization, and radiotherapy, and combined transarterial and ablative techniques, external beam radiation, systemic chemotherapy, hormonal, and immunotherapy. So surgery, we have partial hepatectomy and total hepatectomy. These are the treatment of choice whenever possible, because this has a highest long-term survival rate. So whenever possible, that is only single tumor that is less than of 2 cm. This is preferred. The most preferred treatment of choice is hepatectomy. And what are the negative prognostic marker? That includes tumor size, cirrhosis if there is infiltrative type, vascular invasion is present, multiple focal tumors, lymph node metastasis, intrahepatic metastasis, and lack of capsule. So we have orthotopic liver transplantation. This is an ideal treatment of choice for the candidates that has single tumor less than 5 cm or HCC each less than 3 cm, and the tumor with no evidence of vascular extrahepatic spread. So the limitations is again we have need for chronic immunosuppression and lack of organ donors. So what are the non-surgical treatments we have? We have percutaneous ethanolamine injection. So this is mostly for the tumor that is less than 2 cm with a single application, and in case of large tumor it might require multiple application. So we have percutaneous injection of acetic acid that is used in septated tumors as it has high necrotizing abilities, and we have thermal ablative techniques as well, which use cryotherapy. And we have radiofrequency ablation, which utilizes high frequency alternating current to produce heat around the probe and thereby about 60 degrees Celsius, leading to cell death. So we have transarterial therapies, hepatic arterial infusion of chemotherapy, 5-fluorouracil. So percutaneous transarterial embolization. This is done by an ethiodized oil, but its efficacy improves on adding chemotherapy agents like 5-fluorouracils. That's why it's called chemoembolizations. Okay, patient selection is the liver function should be preserved, and it should be an asymptomatic multinodular without vascular invasion, like I said earlier. And we also have transarterial radiotherapy, where we can use iodine 131 or yttrium 90. So we have molecular targeted therapy, new agents where there is portal vein invasion and N1, M1 disease. We use sorafenib, which inhibits serine threonine kinase RAF1, BRAF, the receptor for tyrosine kinase activity of vascular endothelial growth factor 1, 2, 3, and platelet derived growth factors. So these are responsible for angiogenesis and proliferation. So by inhibiting these receptors, we are inhibiting the angiogenesis, proliferation, migration, invasion, and lymphangiogenesis, thereby preventing the growth of the tumor. So we have 2 trials: combination therapy, resection with adjuvant, either retinol polyclinic acid or the transarterial 131 ethiodine. So this would reduce the recurrence rate. So there are a few distinct variants of HCC, which includes fibrolamellar, clear cell variant, pleomorphic variant, and childhood HCC. So the clear cell variant, this consists of clear cytoplasm, which resembles renal cell neoplasm. It has better prognosis. Pleomorphic, with the name, it is pleomorphic cells, multinucleate, largely likely to originate from primary hepatic cells. So childhood HCC, this constitutes about 25% of pediatric liver tumors. The viral apparatus are associated with this variant. Curative therapy is resection. My reference is from Sebastian and Bailey, 21st and 27th edition. Thank you.